We have a 50-year-old female who presented with right-sided chest pain, dyspnea, and coughing up blood. Her past medical history is significant for the fact that she is a non-smoker and she has no other medical conditions. Her workup included CT of the chest, which showed right lung mass. Brain MRI showed small brain metastasis. Patient had no symptoms. Biopsy of the right lung mass showed adenocarcinoma. Molecular testing showed that she was an EGFR wild type, KRAS wild type, and immunohistochemical test was positive for ALK. Post-progression biopsy was performed, and her mutational analysis showed an ALK mutation, specifically I1171N. She was started at brigatinib at the FDA-approved 90 milligrams lead-in dose, which was later increased to 180 milligrams. She tolerated the treatment well, just had a little bit of a nausea, and she developed a partial response to brigatinib, including the CNS response, which is continuing at 15 months of therapy. To summarize, we have a patient with stage 4 lung cancer with ALK-Rearrangement. Her first line of treatment was crizotinib. Her second line of treatment was brigatinib. This presentation is very typical for patients with ALK-Rearrangements. We have a non-smoking patient. However, I'd like to stress 2 points. Number one, when she was diagnosed, she only had 3 molecular abnormalities tested, which was EGFR, KRAS, and ALK. In current state, we have 4 molecularly targeted agents approved for lung cancer, and so what's missing from her molecular profile is ROS1 mutation as well as BRAF mutation. The second point, which I think is important to make, is we do not make decisions of doing or not doing molecular sequencing based on any information besides the fact that this is a non-squamous non-small cell lung cancer. Current NCCN guidelines recommending molecular testing for patients regardless of gender, ethnicity, or smoking history. So the fact that she is a non-smoker is important, but is not a prerequisite for us to start doing molecular testing for our non-small cell lung cancer patients. Currently, ALK rearrangement happened in approximately 5% of patients with non-small cell lung cancer.